Hello, this is Dr. Samantha Ritchie. This is a talk on buprenorphine treatment for opioid addiction, and it's specifically for loved ones of people who struggle with opioid addiction. So there are three topics I'd like to cover. One is, what is fentanyl and why is it so deadly? Two is, what is addiction and why can't people just quit using opioids? And third, what is buprenorphine and how does it work? Buprenorphine, also called Bupe, is what we do at the Olympia Bupe Clinic. We prescribe buprenorphine for people who are addicted to opiates, which is primarily fentanyl these days. Of note, much of the ideas that I'm going to talk about in this talk are from a book called Never Enough, The Neuroscience and Experience of Addiction by Dr. Judith Grisel. One thing I'd like to talk about is how fentanyl is made. So basically, traffickers that are manufacturing fentanyl often purchase the key ingredient from China because China, at least in the past, has not regulated its sale. Here's how the chemical building blocks become a highly profitable street drug. The first ingredient is NPP, which stands for N-phenethylpyridone. And if you take 25 grams of that and you buy it from China, that'll cost about $87. Then NPP can be combined with about $720 of other chemicals, and that will produce fentanyl. So the resulting 25 grams of fentanyl cost about $810 to produce, but the equivalent amount for selling it on the street is about $800,000. So that's why there's such a big black market for this drug. Fentanyl is really deadly. This is a graph of the different waves of opioid overdose deaths. And you can see wave one, there was a rise in prescription opioid overdose deaths, and that started in the 1990s. That was people taking pain pills. Then there was a rise in heroin overdose deaths when it was impossible to get the pain pills as easily. And those were bad, but nothing compared to what happened when fentanyl got going. And since about 2017, fentanyl deaths have been just staggeringly high. So fentanyl is a white powder, and it's very, very potent. If you look at the picture on the left, you'll see the amount of fentanyl that's needed to kill somebody who has no tolerance to it. It's often stamped into pills that around here are called blues, and they're made to look like oxycodone 30s, but they're not oxycodone. I think it's important to understand that humans have always loved to get a sensation of being outside of reality. We've been finding and using chemicals that do that since recorded history. And fentanyl, like all opioids, can bring on a feeling of utter contentment and can also stop pain. At least that utter contentment feeling happens in the beginning. Opiates are the best drugs we know for intense pain, and opiates come in a whole spectrum of strengths, from tramadol through codeine and oxycodone and heroin and then fentanyl. The problem is something that starts out making you feel utterly content tends to make people after a while feel utterly miserable. After using opiates for a while, the relationship turns sour. The user suffers in proportion to the duration and intensity of the relationship with the narcotic. In other words, if a person's been using it for a long time and using it a lot, they are going to suffer a lot. All opioids work by mimicking endorphins. Endorphins are endogenous morphine-like substances that the body produces. They're the body's natural painkillers. So you can think of them as the body's morphines. And opioids happen to fit into the receptors for these endorphins just perfectly. Many natural opioids in the brain serve a range of critical functions, including modulating activities like sex, attachment, pleasure, and learning. There is a particular tract in the brain called the mesolimbic reward system that is where all addictive medicines work. So what happens is the addictive drug goes to the area called VTA, the ventral tegmental area, and fits onto the endorphin receptors there. Then from there, the fact that there's something on those receptors makes dopamine be released in the NAC, the nucleus accumbens. And that is what makes us want to use it over and over again, because we like that feeling. With repeated exposure to the same stimulus, though, there are smaller and smaller changes in dopamine at that nucleus accumbens. The brain also has natural anti-opiate neurotransmitters. There's a large family of natural compounds that have evolved to counteract the endorphins. They enhance suffering and restlessness. I know that sounds weird that the brain would do something like that, but it does. Repeated administration of any drug that influences brain activity leads the brain to adapt in order to compensate for the changes associated with the drug. So if you use any drug in the brain is going to use substances that will counteract the effect of the original drug. So you might wonder, why would we have natural anti-opiates? Well, the reason is because pain is so important. Pain has two primary purposes: to teach us to avoid dangerous situations and encourage recuperation after failing the first lesson. So in other words, it teaches you to not walk on a burning branch, and then when you do walk on the burning branch, it hurts afterwards, and so you don't keep walking so your foot has a chance to heal. Our survival depends on fine-tuning our pain sensitivity. Not too much pain, so we have natural opiates, and not too little, so Mother Nature made anti-opiates. It's important to note that if you have somebody who's born without sight, or someone who can't hear at birth, they tend to live long, natural lives. But people who can't feel pain, they tend to die early, because they injure themselves and they can't tell and they don't do anything about it. Bodies want to maintain homeostasis. Homeostasis just basically means keeping things the same. And anti-opiates restore the brain to its baseline most efficiently. If you've had an opiate, your brain's going to make an anti-opiate. There's a bunch of examples of homeostasis. One is body temperature. You know, if you get too hot, you sweat, or if you get too cold, you shiver. Blood glucose levels, the same kind of thing. The body wants to maintain a very small range of appropriate blood glucose levels. Blood pH, water balance, and pain levels. Those are all things that the body wants to have only in a certain range. And there are 3 rules of mind-altering meds. This is from Dr. Grizel's book. The first is that all drugs act by changing the rate of what is already going on. For example, fentanyl fits in the receptors for the endorphins. So it's not like fentanyl makes new receptors happen. It's that there already are receptors in there. And all drugs have side effects. And thirdly, the brain adapts to all drugs that affect it by counteracting the drug's effects. The brain's response to a drug is always to facilitate the opposite state. Therefore, the only way for any regular user to feel normal is to take the drug. These are just some examples of opiate effects and their withdrawal symptoms. So, like analgesia, the withdrawal symptom is pain, or euphoria, the withdrawal symptom is irritability and dysphoria. A common one is constipation when you're using the opiate, and diarrhea when you're withdrawing. And these withdrawal symptoms are partially caused by those anti-opiates. This is a complicated, somewhat graph, but it's important to pay attention to. Basically, early in use, which is the graph on the left, you can see that in the A process, which is what happens with using the drug because of the drugs such as fentanyl, you get a rise from your set point, which is mood or how you're feeling about life. It goes way up, and then eventually it goes back down and tends to dip down below the set point. As you can see on the dotted line there, that's what the A process would look like without the B process, but there's always a B process. The B process makes the person actually have a sensation that's more like the not dotted line. And so what happens is the person does get high, but doesn't get as high or enjoy it as much because the B process kicks in. On the right, you see the graph of a person who's been using drugs for a long time. The A process is the dotted line of what would happen if the B process didn't exist. But the B process does exist, where the body kind of fights back with the anti-opiates, and you get the line that's got much less of a high and basically is following the set point line, then goes well below the set point. Here's another way to look at it. When a person initially gets high, they have euphoria. And each time they get high, the euphoria is a little bit less. Then pretty soon they're using just to feel normal, and the rest of the time they're feeling pretty awful. And what medication-assisted therapy is supposed to do is help a person feel normal all the time, not high or depressed. The definition of addiction can be as simple as continuing to do something that you know is harmful. Or you can have a more complicated answer, like it has multiple components, including craving, tolerance, dependence, and deleterious consequences. Another one that's not usually in the definition of addiction is that often there is denial. There's often denial that there's a problem with the drug. For example, somebody might say, I'm miserable because I'm homeless, and it has nothing to do with the drug. I have to take the drug because life is so hard. Often, life is so hard because of the drug, and if they didn't use the drug, they wouldn't be homeless. But that's hard to see when you're in the middle of addiction. What causes addiction? Well, there's many causes of addiction that we know about, and there's probably more that we don't know about. Genetics have to do with it, although there's no one set of genes that we know causes addiction. There's environmental clues like culture and access and peers and stress and trauma. And there is development. Trauma as a child increases your risk of using drugs. Adolescent exposure certainly increases your risk. Having mental health problems increases your risk. One thing to understand is that people who have used fentanyl for a long time are stuck. They are trying to maintain a habit that is both expensive and time-consuming. And soon it's not even fun anymore. They are just using so that they don't get sick from the withdrawal. But when they try to quit, they run into a constellation of not feeling well, having lots of stigma about it. They often have lousy self-esteem, and the system that we have for trying to help people with opiate use disorder is complicated. And to make things even worse, their brains aren't working very well. Their prefrontal cortex, where they're supposed to be making plans, just doesn't function as well as it should. So buprenorphine can help. Buprenorphine is what we do at the Olympia Bupe Clinic. It comes in different formulations. There's two formulations that you can put under your tongue. One is tabs, like on the left, and the other is the films, like the picture in the middle. And then there's also monthly injections you can get. And there's another type of injection that you can start by getting weekly. All of these work and have different pros and cons. But for many, many people, the buprenorphine is able to allow them the ability to to get their lives in order. Bupe is a weak opioid in terms of euphoria or getting high, but it is an opioid. You can think of it as if fentanyl is a Niagara Falls, buprenorphine is a big garden hose. So it just doesn't do much at all for someone who is used to using fentanyl, even though it is an opioid. It has a very strong connection to the receptor, and so strong that if you have buprenorphine on board and you slip up and use fentanyl, you tend not to overdose because a lot of the fentanyl just goes by the receptors because the receptors are already full and the buprenorphine doesn't let go. So one thing that people wonder is it just substituting one drug for another? The reason I don't think it's substituting one drug for another is that if you ask somebody who's using fentanyl, what's the last thing they think of at night? It's, am I going to have enough fentanyl tomorrow? Because I don't want to get sick. And it's the first thing they think of in the morning. Whereas with buprenorphine, they just take the medicine and get on with their lives. It's not something that people really kind of look forward to using buprenorphine. Another thing about buprenorphine or methadone is that it really does save lives. This is a standardized mortality rate from studies done in 2015 and 17. So this is a little old now. But as you can see, with no treatment for people who use opioids, the death rate is a 6 compared to a 1 with the general population. And if you get a person on medication-assisted treatment, it falls down to less than 2. So it clearly saves lives. This is another study that's, again, old now, but this study showed that to prevent 1 death per patient per year, you'd only have to put 3 people on buprenorphine. So what can you do if you have a loved one who uses fentanyl? You can support them emotionally, celebrate their steps towards health, even if it's 2 steps forward and 1 step back. And remember that this is a brain disease. Remember about the brain wanting to maintain homeostasis, and understand that they can't get rid of this disease by willpower. It just doesn't work that way. You can't willpower your way out of diabetes. Well, you can't really willpower your way out of opioid use disorder either. And help to fight the stigma around addiction. If you could avoid phrases like he's an addict or he's a junkie, that's just not helpful. You might want to say instead he has opioid use disorder, because language really does matter. Other things you can do, remember that everyone's journey through addiction and recovery is different. Some people benefit from groups like AA or NA, and you could encourage your loved one to go. But some people don't benefit from that. They find it triggering. So I would listen to what your loved one has to say about that. And then note that some people need buprenorphine for the rest of their lives, and some people only need it for a short period of time. If your loved one says, I need to stay on this buprenorphine because I'm scared to get off it, even though they've been on it for 10 years, I just encourage you to let them stay on it. They know how dangerous it is and how easy it is to relapse. This tends to be a disease that is relapsing and remitting. In other words, it likes to bite you in the butt if you are not vigilant about watching out for it. Another thing you could do is learn how to use Narcan and have some around. We can teach you at the Bupe clinic, and we often have samples we can give you, but Narcan really does save lives. Narcan is the drug that counteracts opioids after a person has overdosed. Another thing that you could do is consider joining Al-Anon or another support group for families of loved ones, of families of people who use opioids. And another thing is acknowledge that loving someone who has the disease of opiate use disorder is very difficult. It's harder than having a son or spouse or daughter who has heart failure or diabetes or cancer even, because people who have opiate use disorder are stigmatized and often do things to their families that they wouldn't do if they didn't have addiction, like they lie or steal or do all kinds of things that that would not happen if a person had cancer or heart failure. And cut yourself a break if you're at the end of your empathy. You're only human, and this is a very difficult situation. Remember that it's a marathon, not a sprint. Most people with addiction have a non-linear path. And success can mean all kinds of things. If they are still alive in 3 years, that may be success. Success doesn't just have to mean complete abstinence from drugs. Okay, that's it. I hope that's been helpful. Please know that if you have any questions, you are always welcome to come and talk to us at the Bupe Clinic.